Hannah is starting. Okay. All right. So yeah, so I was saying thank you for the platform because, you know, I talk about this at other spaces and other platforms, and we never really hear about it locally. And it is important that I think people around us understand what we're doing and why. So thank you for that platform. So this is a talk, I'm just going to say disclaimer, I'm recycling. I did this at the Boston Grand Round last month at Boston University. And it was because people were interested in how different our training platform is and what were the things we had to consider in our degree. And I thought it's useful for us to sometimes have this conversation. So it's not as long. I've cut out some of the stuff, so I might talk through it if you had questions that are not reflecting here, but let's start. Okay, so as Petrus has mentioned, part of the journey here has been with me trying to coordinate an effort to sort of regulate, I want to say, infant mental health education and practice in South Africa, because what we found was that there are a number of things you can do to get your specialization in this field, but a lot of it comes from the global north. It comes mostly from the US and from Europe, and it's not always suitable for our babies locally. So this talk is basically trying to touch on the challenges, but also some of the strengths, I think, in the program. So, okay, so I think the first thing to understand is why this field. And so if I think about setting the scene, what we understand is that maternal mental health disorders are 3 times more prevalent in low middle income countries such as our own than in high income countries. And what happens as a result is that various aspects of mothering, including attachment, including attunement, emotion regulation, all the words we know, all of these things are put at risk. And it's always useful to remind ourselves that there are approximately 250 million children younger than 5 years of age in low middle income countries that are estimated to be at elevated risk of not achieving their human potential because of exposures to extreme adversities in our settings. And so there are many identifiable risk factors. Unfortunately, some are disproportionately present in Africa, and this contributes to the loss of the human potential. And if we think about it, and not to go through the science of early development again, but if you accumulate the number of adversities that begin in the perinatal period, so before conception, continuing throughout prenatal and early life, all of these things have a risk of disrupting brain development, and by extension, early learning and attachment. And so expanding the understanding of these risks that lead to the poorer outcomes, what's protective, what's actually contributing to the resilience, may actually be critical to us improving disparities. It's also important for us to remember context. And unfortunately, as Mark Tomlinson reminds us often in the literature, that there's a dearth of evidence on the diverse experiences and the conditions that either promote or impede infant development. The bottom line is we just don't know enough. And context-related limitations continue to constrain how we understand children in the context of our setting. Now, it's important to remember that Africa is not one place. It's home to multiple cultures. There's distinct organizations of caregiving relationships that underlie the development of attachment. And in fact, our concept of attachment and how we see parenting may differ not even just between South Africa and, say, up north in Tanzania, but basically between the Western Cape, for example, and the Eastern Cape. And as a result of this, our contexts remain understudied regarding what do we define as good enough attachment or as helpful attachment. And the continent's cultural diversity may actually hold quite important messages that are, or truths that are necessary for us to understand this complex relationship. And we all come back to relationships because that's what infant mental health is all about. It's about the relationship between the infant and its caregiver. And these relationships are the conduit through which these infants will experience and be able to negotiate these environmental risk factors. We know also from basics of IMH that a child's emotional development is significantly shaped by the nature of their relationship to their attachment figure. And for young children, just to remind you that having a relationship with a responsive, warm, available caregiver is likely the most important factor for positive outcomes. Now, mental health affects nurturing care. We talk about nurturing care. The WHO puts out their briefs around what children need to survive and thrive. And infant mental health reminds us that it is about the quality of the caregiving in these relationships, especially this mutual adaptation of the infant and the caregiver that will contribute to nurturing care that children need. And without the appropriate regulation from a supportive caregiver, all these exposures that we know are inevitable in Africa and in settings such as ours can result in wide-ranging biological and emotional disruptions. So just to remind you that perinatal mental health, which is really closely interwoven with infant mental health, is critical in South Africa because our local studies really report a 33% prevalence rate of, for example, maternal mental health in terms of depression, perinatal depression. And there are many myths about treatments of perinatal mental health disorders, and less than 10% of women in South Africa with psychiatric illnesses get any treatment. The vast majority go unscreened and untreated. And so what also happens is that the challenges of mental health in maternal mental health in the perinatal period is overshadowed by systemic issues in the health system. So there's lack of collaborative care between obstetric, antenatal, and psychiatric services. There's stigma. There's cultural misperceptions about what constitutes baby blues versus perinatal depression. There's a lack of sustainable service delivery models. But all of these can be addressed, we think, in small ways by general and mental health care professionals that encourage an awareness of the impact of perinatal mental health on early infant mental health, as well as the ability for us in this service to be able to offer early dyadic screening and intervention. And we know it's widely accepted that if you intervene in the first 1,000 days of life, this alters developmental trajectory and can protect children against environmental risk factors. But to do this, we need a few things to happen. And what we need is to be able to screen effectively. We need to use appropriate tools, but we also need to know how to screen and when to screen. Healthcare workers have to be trained to identify mental health issues and to manage this in primary healthcare settings. And we really lack when it comes to providing this support in the primary care setting. We also have to be able to identify and manage red flags early. And all of this is great, but we also need resources to support this intervention. And that brings us to the problem of resources, care, and training. We have to be able to reimagine, to reinvent the role of higher education and training and healthcare provision. We can't do more of the same because it's not actually working well enough. Innovative and creative thinking is required to reimagine the potential of universal access to healthcare. And this is really a message from UNICEF. And UNICEF projects that the expansion of Africa's child health population is going to increase by 1 billion by 2030, with a disproportionately small availability of healthcare personnel to services. So while the numbers of children and the demands increase, the kind of commitment to resources to care and training remains unfortunately the same. And what this actually means practically is that we need an increase of more than 10 million skilled healthcare workers to keep up with this demographic transition. So the question is, who is going to train these professionals? And what do we do when there are no healthcare professionals available to provide the service in a fragmented health system within a resource-depleted healthcare setting? And so really in walks infant mental health, a rapidly expanding field. And that this expansion of IMH services in Africa relies largely on the provision of education and effective infant training structures. Now, in stark contrast to international standards of care, the African continent has offered no professional postgraduate degrees focusing on infant mental health. And there's dime a dozen of these that you can get online internationally. There is now a need to develop interdisciplinary graduate programs to prepare this diverse prospective workforce for specialized intervention, particularly in the practice of IMH. And offerings to date, unfortunately. So there are offerings, but these offerings have only emerged from the global north and are largely unable to respond to the need in Africa. And so I'm talking about programs that are offered from Denver, from Australia, which is actually not the global north, but still the practice principle is the same. A lot comes out of the Tavistock. It comes out of the Scandinavian countries. There's quite an active IMH support across Europe. But really translating that into the African population is very difficult. And that is because what we need are African solutions for Africa's children. And so the promotion of early cognitive and emotional development is a core aim of this field. and the ways that the care and the attachment relationships are given form is not universally the same. So this raises the challenge of shaping the current teaching modules models, that are sensitive to context and culture while still staying true to the core principles of IMH teaching. So while IMH is well established in Euro-American contexts, questions have been raised about how do we tailor it so that the contexts may differ from those in which those models were developed, but we still keep true to the core promotion of early cognitive and emotional development. And so one of the very first papers we wrote in 2017 was that was published in a British Journal of Nursing. And it spoke about us developing a program that would address the need for Afrocentric training. And so at this point, under the mentorship of Prof Berg, who had proposed at that point a new degree program, considering it a Master of Philosophy in IMH. And she felt that it could target training competent clinicians to attend to the mental health of children in a resource-limited setting. So it was a novel idea that really was very quickly, I want to say, snapped up by Stellenbosch University. And so it brings us to the question as to why Stellenbosch University? Well, traditionally and historically, Stellenbosch University has identified as a predominantly Afrikaans language university, very often to the exclusion of a majority of students of color. And the reason that this was ripe for acceptance at Stellenbosch University was because they had a new commitment around 2016 to curriculum renewal, really focusing on transformation, on social impact, and decolonization. And so by a decolonization approach, what this was really speaking to was bringing in learning material and experiences in local settings, so local hospitals in the African context. They were asking us to supplement knowledge, perspectives, and research from Western countries with those from South Africa and by extension in Africa. And they were looking for a platform for scientific sharing and local evidence-based research agenda that was urgently required to reflect the local setting. So as you can imagine, this was fertile ground for welcoming innovation, sensitive teaching, and multicultural classroom contexts. And so we set up the MPhil. So the aim of this MPhil degree was to be accessible to a diverse group of students in health, but also allied health domains, and to develop practitioners who were skilled in observation, but also to generate data that would provide the basis for ongoing context-sensitive research and theorizing. So when we looked at who the potential students would be, we wanted them to not just be kind of floodgates to everybody, but really those who wish to develop their understanding and clinical skills working with infants and parents, and those who are interested in participating in research, service development, delivery, and evaluation. And we pitched it as offering an opportunity to train local, previously disadvantaged population groups of students across the allied spectrum of child health domains, including not just the traditional models, which was psychology and psychiatry, but also occupational therapy, clinical social work, nursing, and recently included dietetics. Because overall, what this does was speak to the multidisciplinary nature of IMH. And unlike other master's programs, this prided itself on offering a multicultural classroom. So by multicultural classroom, we didn't just mean different racial groups, but really diverse professional backgrounds. So an opportunity to collectively train and learn from each other in a field with difference. So our first advert that went out, and this is a recent one from 2021, was really saying that we are looking for candidates who are interested in a program that delivers a South African-centered curriculum. So we're not training potential IMH specialists for export market. This was very clear that this is really a field within South Africa, and the furthest expansion would be to the rest of Africa and lower middle income countries. So this is what we were setting up for. And our modules included infant observation, clinical practical, which is really about clinics and actual patients. Infant observation is like the Tavistock model, which basically follows a pregnant woman post-delivery and then for 2 years. And then theoretical models, basically to tie it all together in terms of the science behind it and a research assignment. So many of the principles of existing models of intervention and training are useful and they are applicable across different settings, but appreciation of this local context is still needed. So if we think of South Africa, the ongoing contextual factors that we really had to consider were social inequalities, the ongoing legacies of racism, the high rates of maternal mental illness, and of course, intimate partner violence. And cultural variations about childbearing and rearing was really exciting for us because what South Africa has, which is kind of unique compared to other offerings of IMH, and I mean in the global north, is about the diverse family forms, which really makes us feel quite difficult to navigate. If you think about the South African context, where most children are looked after by either grandmothers or extended family members, or aunties or neighbors or older sisters, and sometimes nannies, but mostly because mothers have to become nannies for other privileged children. So we really needed to rethink about this, holding the South African child quintessentially in mind. So addressing this need in South Africa, there is a shortage of trained clinicians, regardless of whether this is IMH specific or not, but really a shortage of clinicians who can manage infants and caregivers. That's a major barrier to providing adequate services, not just here, but also by extension on the continent. And so resolving the gaps in human resources entails the use of non-specialists to deliver mental health and other interventions. In fact, the sexy word is called task shifting, where the delivery of healthcare using community health workers, allied professionals, nurses, etc., has been largely successful in low middle income countries, including in populations that are considered to be especially difficult to treat. And so what we had to do was to make better use of the expertise by instituting enhancements and innovations that will increase the quality and the relevance of clinical service. So to bear in mind, we did not want to create psychologists or psychiatrists out of the dietitians or the OTs or the nurses. That was not the need. The need was to enhance what people were already doing with an added bit of information and training in a specific field. So all of this sounds great on paper, right? But with the diversity came challenges. And so one of the big things that really worried us were the teaching challenges. And this was something we published in 2019, where we looked at the concerns about teaching in an ethnically and culturally diverse classroom that we unfortunately underestimated. The legacy of colonial education, of apartheid-based education in South Africa began to manifest itself in the quality of the basic education that invariably affected the quality of the tertiary education of the students that we were seeing. So some of the considerations that we really had to bring to the fore was the integration of the background of professional training and skills and the varying levels of language ability and scientific expertise. So while people were health professionals, right, and while they were considered allied professionals and sort of registered for work in the field of health, was not the same. So the background training that, say, the dietitian got or the psychologist with a Bachelor of Arts degree was very different from the training a psychiatrist got or an occupational therapist got or a nurse got. And so things we thought was standard information that everybody knew suddenly was not so. And so developing the skills and the ability to formulate local evidence-based guidelines became hard because the essential pedagogical outcomes in training the infant mental health practitioners had to change. And so a diverse classroom to teach in requires new levels of self-awareness, knowledge and skills, not just on the students, but also of the teachers. And so while diversity in academic settings has been related to more positive academic outcomes for the students, there are also great challenges for the teachers on such programs. And so what we were noticing was really the educator experience, which was a huge challenge in teaching in this diverse classroom. So we know what we know, but do we know how to filter this out to students who don't have the same background, but are doing the same degree? And so an example of these kind of diverse classroom challenges that we were presented with were firstly language and racial differences. Everything is not the same. people's first language is not all English, and we speak with a level of English and science English that is really hard to accommodate if people don't come with that background. There was also cultural diversity, so community and personal identity, which we were very excited to notice because it was what we were saying or theorizing from the start, which is not all ideas and ideals of caregiving models are the same. Professional differences, an OT approach is very different from a social worker, which is very different from a psychologist. And then, of course, academic baseline differences, which I've mentioned in terms of health versus humanities, or age, an older student versus a younger student versus your comfort with different teaching methods, including blended learning and virtual learning. And how do we measure this outcome? That was hard for us because when we ask someone to write an essay and you get a psychologist writing a beautiful 3,000 word essay, and then you get an OT giving us a practical demonstration of how they see things, which is better, which is worse? What are we actually marking? Are we marking someone's psychological flexibility with their words and essays, which is what their degree teaches them? Are we marking down someone who actually has been taught to produce stuff in a different way? Are we actually measuring English competency, or are we measuring practical competency in terms of how do we apply? So it's been a really challenging time for us in terms of understanding education and health education. There's also content challenges. So this is really something we wrote about with the Department of Social Anthropology earlier this year. And this normative presumption of singular care as neatly defined family units really runs aground when we examine and challenge the concept of there being just a mother and a child as a universal norm. Like I've mentioned, it's fathers, it's daycare mothers, it's grandparents, it's aunties. In South Africa, there is a state and policy recognition that the primary caregiver may actually be someone other than the biological mother. Maybe the same-sex partner, maybe an older sibling, it can be anyone. And systems of care of children that take on diverse forms have to be accounted for in health and education policy. We can't have this archaic idea that it's all about the mother and the baby, because it may not be reflective of the setting that we're in. And similarly, nurturing the field of infant mental health in this region requires us to rethink some of the foundations of our methods and interventions, just the words we use. So for example, somebody gets referred for mother-baby therapy. There's just presumptive assumption that this is the biological mother, or this is the actual mother and the child, but it may actually be a caregiver of a different type. So if we reflect on approaching these challenges, we had to think about the course content, and we needed to rework it to reflect multicultural sensitivities. We needed to rethink the evaluation of the candidates' needs to take into account the differences that are unique amongst students. And at the end of the modules, as the faculty, the teaching staff, we needed to consider, what is content competency? Do people understand what we're teaching, and can they apply it to their setting, rather than can they communicate that in an English colonial language competency kind of basis? But we also needed to ask a really important question. Who are we training? Are we training local practitioners to become IMH specialists? I don't think so. Are we wanting to tailor the specialty of IMH to the local practitioner needs? Maybe. Do we make experts out of clinicians, or do we try and upskill generalists to think in an infant mental friendly way? And that's what I think we're trying to do. What do we enlist as essential and evidence-based practice? And who is providing this information for our contact? One of the things I always tell our registrars in supervision is, evidence-based information is great, but what's the next best thing that we can apply in our setting that is context sensitive and that still gives children the best option of care? And so this is a useful article that really brings again the major bias that we face in Africa. And this was an article that was published by our other Stellenbosch colleagues, which is Mark Tomlinson and Leslie Swartz, about the imbalances in the knowledge about infant mental health in rich and poor countries. Too little progress in bridging the gap. And so the shocking results of this review, or actually shouldn't be that shocking if you're in the field, is that they reviewed a decade of articles published on infancy, and to see whether the status of cross-national research changed in the subsequent decade. And what they found was that despite slight improvements in research output from the rest of the world, only 2% of articles, now think about that, 2% of articles in 11 years considered data from lower middle income countries in a place where 90% of the world's infants lives. I mean, it's shocking. And these discrepancies are still indicative of the progress that's needed. Because what we're doing now is we're saying the vast majority of infants are born in poor countries, but almost all our knowledge that we have about what infants need is coming from rich countries. How does that even make clinical sense to anyone? And so the promise of research is really a topical thing. Since most of the IMH countries, IMH literature has emerged from high-income countries, the interventions taught in Africa are going to be informed by these findings. We have to, right? Because we have to listen to what the evidence shows. However, IMH research has also shown us that the cultural context in which parents and infants are embedded has to be understood and appreciated before an intervention can be meaningful, no matter how good that intervention is, no matter what the RCT tells you. It has to be embedded culturally in an appropriate way. And so going back to our degree, for their research assignments, the students are trained to formulate a research question that is close to the ground. So in terms of local context and worldviews, and we try not to rely on Northern validated questionnaires. And I'll tell you the problem with this. So we encourage them to think critically when they're applying theoretical contexts and concepts. And their research questions are asked to interrogate given categories like family, attachment, or play. So some of the research projects over the last 5 years have been really simple questions, but really giving us meaningful information. So what do local antenatal services view as supporting attachment? No surprises there. The results show us that nurses believe that if you breastfeed your baby, you bond well, which again, we know is nonsense. How do we screen for red flags in infant mental health in a diverse and highly unequal society? Do we understand perinatal depression? And how does this impact on how babies are fed or how mothers respond to those feeding behaviors in a context of resource-limited settings? How do caregivers understand play? What does play mean to them? Is it the same thing that we're reading in the Tavistock Handbook of Play? How does this compare to conventional models of what children need? Is there a way that we can encourage fathers' involvement? So these kind of really simple research questions that are asking a valid question locally. We published some of it. This is just some of the, I'm only highlighting two, some are in review. This is one that was published in Frontiers that looked at fathers' experiences of participating in a baby theater in Mowbray, Woodstock, and then some positive relational experiences that infants have that influence outcomes. And so we're left with this idea of the ambition of innovation. So local research in IMH. And I'm really intrigued by this idea of innovation at Stellenbosch University, because innovation can't be that we develop an app, that we have some tech answer or some tech solution to it. It has to be, are we rethinking creatively? That's also innovation in a field, not just a tangible thing, but maybe a more elaborate question to that. And so these answers to the questions, I think, are crucial to understanding infant social life, mental health in diverse contexts, and formulating effective interventions. That's where the innovation is going to come, out of the local research. And so we need these research to define diagnostic tools, to look at algorithms, to look at what works in primary care settings. How do we measure this effectiveness? How do we look at novel treatment delivery strategies? But the problem is, we have to publish this. And scientific publications relevant to IMH lag behind those, and forget high-income countries, lag behind other things in local settings. So you don't even want to imagine how well-funded research is for things like HIV and TB in South Africa. And so IMH gets, or even child psychiatry gets really tossed to the side because it's, again, not a sexy topic. It's a problem that perpetuates both global health inequalities and inequities, and it also entails missed opportunities for important scientific research. And that we have to talk about is that Euro-American-centric bias. I love this word because a significant challenge to addressing the questions is how difficult it is for us to actually publish locally relevant and culturally sensitive research. So I'm sure if you listen to what I've just said about the questions, they're important questions, right? And they're meaningful for clinicians. And I'm pretty sure the psychologist or the nurse sitting in Ghana or Uganda also wants to know what the answer is. But where must they read it? Why can't we publish it? Why are we not publishing it? We're not publishing it because whatever little exists is colored by limitations in expertise and training in research methodologies, right? We can't do, at this point, with our capacity, with our resources, we can't do these really big scale kind of gold standard ideas of what makes good quality research. And there's also this challenge of the Eurocentric expectation. So a lot of peer-reviewed journals claim to publish for an international readership, but read this as, they say they regard highly contextualized outputs like ours as inappropriate for the high-income countries. But actually, that's not our audience, is it? So the question we have for IMH now is whether we replicate other studies that are getting published, that are getting that platform, that utilize acceptable methods and frameworks that tempt this international reader engagement, or actually do we say, I don't think so. Let's rethink these research questions. Let's mold the field on the African continent. Let's kind of regroup and think, how do we get this information out there if we can't publish it in these highly contextualized Eurocentric journals? A really, really good article that was published this year in The Lancet came out of a psychologist in Durban called Tameshri Naidu, and she talked about northern ventriloquism. Again, a wonderful concept. She said this happens when lower middle income country scholars enunciate high income country ideas to access globally competitive grants and publish in high income journals. Doesn't that feel true? It feels so true, because what do? We try and adapt our ideas to meet the expectations of these other countries so that we can then apply for the same grant, we can then publish in this high impact journal, and we get our academic currency. The university pats us on the back and they say, here's your DHET subscription money, well done. And the problem with this is that high-income country scholarship uses its position to dictate structures, to set priorities for the content, relevance, and timing of publications. And this is not okay. It's not okay for us. It doesn't speak to what we're trying to do. And academic English is the key marker of academic authorship. So ALMIC researchers might collaborate with high-income country-based colleagues, and they westernize the voice and the arguments to their manuscripts to ensure publication. I do the same. And we need to call ourselves up on what is it that we're actually doing for whose benefit. So in the infancy of our research journey, I like to think we're actually choosing to challenge the norm and addressing this challenge through a reflection on the fit between established models and local contexts. So we calibrate where necessary and possible and develop alternatives where not. And we're thinking more expansively that this is best done through interdisciplinary dialogue. So what we're doing is we're partnering and we're trying to collaborate with other faculties that are more sensitive to this. So a good example of that is health and humanities through social anthropology, which kind of seems to be speaking the same language that we're speaking, which is different from the traditional science. And so global social medicine is really where we're finding a fit, because their approach emphasizes the knowledge flows are multidirectional. And it foregrounds a global commitment of learning to learn from others, which is really what we want to do, right? Through an openness to what attention to local context and context disciplinary engagement can teach us. So looking ahead, how do we make and how do we expand this degree and make it accessible beyond South Africa? Currently, I'm in the process of creating an online distant learning platform. So we basically trying to convert our modules, some of the modules, into what we think a generalist would need to know, into a 3-week program that you can complete online from anywhere in South Africa or the rest of the African continent, so that we can teach you the basics of what is locally important for IMH. What do you need to consider? What are the local screening tools? Do you understand the basics of it? And is it basics that are contextually relevant? And we view to extend the scope and the variety of exposure to other allied disciplines by research and clinical collaboration. So in summary, I think this is the last slide. There is a need to urgently develop and implement evidence-based, cost-effective health intervention packages that we want to deliver on a wide scale, that we want to reach the poorest families, that we want to have positive health outcomes. And this requires us to integrate programs such as our own and others that are going to contribute to improve maternal and child mental health, but also to promote more efficient and effective use of resources. Thank you. Are you you're muted, Petrus? Oh.
That's not very good if I'm muted. The first thing we have to do is to give Anusha a huge round of applause, from everyone. Thank you for a brilliant presentation. And I'm sure this is a good time for us to stop the recording if Rihanna is about.